Hi everybody and welcome to our module on malaria. So malaria is very high yield for your boards and you need to know a bit more about it than the other protozoa, so that's why we have our own separate module here. So first of all, let's define malaria. Malaria is a protozoal infection caused by a protozoa called Plasmodium, and it's an infection of red blood cells in the liver. And it's very rare in the United States and in Europe. It usually occurs in places like the tropics and the subtropics. And it's high yield to remember that Africa is the most affected continent. And the reason you should remember that is because in a board question, malaria is usually going to be someone who returns to the United States after a trip to Africa. The way you get infected by this protozoa is from a mosquito bite. The female Anopheles mosquito bites you and then transmits the protozoa into your skin and blood via its saliva. As I said before, the name of the protozoa that causes malaria is Plasmodium, and there are a couple of different species, and the malaria from each species has distinct features. So Plasmodium vivax and ovale cause malaria with one set of features. Plasmodium malariae causes malaria with one set of features. And then the most dangerous form of malaria is caused by Plasmodium falciparum, and we'll talk about that in a little bit. So you need to know something about the life cycle of malaria for step one, but the life cycle is complex and you can get easily bogged down in the details. So what I'm going to do is walk you through the life cycle and then I'll give you a couple of key points that you can remember. So the way a malaria infection starts is with the bite of the female Anopheles mosquito, and then the saliva transmits the protozoa into the bloodstream, and from there it goes to the liver. And the form of Plasmodium that transmits from the mosquito into the bloodstream is called the sporozoite form. So that's the infectious form, the sporozoite. And once it goes to the liver, it's going to live there for about a month, and the patient's going to be asymptomatic. So it's high yield to remember this. Someone may come back from Africa and not get sick for several weeks, and that's because the protozoa is living in the liver getting ready to cause disease. What happens to the sporozoites when they get to the liver is that they invade the hepatocytes, and inside of hepatocytes they mature into multinucleated cells called schizonts. So a schizont is a form of the protozoa that contains many, many nuclei, and it's getting ready to rupture into lots and lots of little daughter cells, but it hasn't done so yet. So it's a big cell containing lots of nuclei. And this is called the pre-erythrocytic stage because the protozoa is living in the liver and it hasn't reached the red blood cells yet. And remember that this stage is usually asymptomatic, so patients don't know that they're infected. Eventually those schizonts will rupture, and like I said before, when they rupture they're going to form lots of little daughter protozoa cells, and those daughter cells are called merozoites. And these are the cells that leave the liver, go into the bloodstream, and invade the red blood cells. And once they invade red blood cells, it becomes called the erythrocytic stage. Inside the red blood cell, they form another stage called the trophozoite stage. And the reason this stage is important is because this is the stage that you can see when you look at peripheral blood smears under the microscope. The trophozoites look like little rings, and we'll see some pictures of those later. Inside the red blood cells, the trophozoites mature to schizonts, just like what happened in the liver. And when they do this maturation inside of red blood cells, they are digesting red blood cell proteins, especially hemoglobin. And the breakdown products are toxic to the red blood cells, so this is how they cause disease. Eventually, merozoites are formed again from the schizonts, and this lyses the red blood cells. And this process of forming schizonts and lysing the red blood cells and releasing merozoites occurs at regular intervals, 48 hours or 72 hours. It depends on the type of infection that you have. And this is why patients with malaria get cyclic fevers. Their fever spikes every 48 or 72 hours as the schizonts are rupturing the red blood cells and releasing merozoites into the bloodstream. So here's some of the key points to remember. The protozoa goes to the liver right after the mosquito bite, and the sporozoites are the infective form that's transmitted from the mosquito to the bloodstream. There's an incubation period of about a month where people are asymptomatic. Eventually, merozoites are released from the liver and they infect the red blood cells, and this is what leads to symptoms. Plasmodium matures and grows inside the red blood cells, and eventually those cells rupture and release merozoites again, and this cycle of maturation and release is what leads to the cyclical fevers. So here's a picture of the life cycle of Plasmodium, and you don't need to know all the details on this slide, but let me just walk you through it so you understand how what I just told you fits into a picture like this that you might find in some of your textbooks. So step one is the mosquito taking a blood meal and injecting that infectious form, the sporozoite form, into the blood. From there it goes to a liver cell where it matures into a schizont, and then the schizont ruptures and releases those merozoites into the bloodstream. The merozoites infect the red blood cells and form those ring stages that we're going to see pictures of in a little bit. Those are called trophozoites. And then it matures into another schizont, and the schizont ruptures again and releases more merozoites, which can infect more red blood cells. And this cycle over here going around and around is what causes the cyclical fever pattern. So let's talk about some of the common symptoms caused by this life cycle of the protozoa. The first classic symptom is paroxysms of fever. So people with malaria have shivering and chills followed by a high fever. It's often occurring at regular intervals like 48 hours and 72 hours, and we'll talk about this later. This is variable depending on which species of Plasmodium has caused the infection. Anemia is going to be a classic symptom of malaria, obviously, because those red blood cells are being destroyed by the infection. The severity varies by species of Plasmodium, and it can be a hemolytic anemia and sometimes lead to symptoms of jaundice. So people with malaria can develop yellowing of the skin. The spleen is often enlarged because it's trying to clear those infected red blood cells. And then finally, there are lots of non-specific symptoms of malaria, things like fatigue and malaise, headache and arthralgias. Sometimes there's cough or vomiting or diarrhea. Rarer symptoms of malaria are things like altered consciousness, especially when febrile. The high fevers can make people disoriented and confused. Also, we'll talk later about how certain forms of malaria can cause capillary occlusions. You can see seizures. There's something called black water fever. This is patients who have renal failure with hemoglobinuria. So the hemoglobinuria makes the urine very dark, and that's why it's called black water fever. Malaria can cause shock, and most of the severe symptoms are due to Plasmodium falciparum. Remember, this is the worst form of malaria to have, and we'll talk about why in a little bit. Now let's talk about the different species of Plasmodium and what's unique about infection with each type of protozoa. So Plasmodium vivax and ovale you can think of together because both of these species of Plasmodium cause the same symptoms and clinical picture. So these two Plasmodium classically have a 48-hour cycle of fevers. It's called a tertian fever pattern because the fever occurs on day 1 and day 3, but there's no fever on day 2 and day 4. And a very important thing to remember about infection with these two types of Plasmodium is that they have a dormant form in the liver. They have a form called the hypnozoite form, which can live in the liver for a long time, and people can have recurring infection months after resolution. It's for this reason that people with malaria are almost always treated with primaquine, because primaquine is the one drug that treats Plasmodium vivax and ovale liver disease. It doesn't treat the active form in the red cells, but it does treat the liver form. And so if you fail to give someone primaquine, then they'll have a relapse many months later because that dormant form was sitting in the liver and has reemerged. The only thing you need to remember about Plasmodium malariae is that it has a 72-hour cycle of fever. So there's a quartan fever pattern with fever on day 1 and day 4 and no fever on day 2 and day 3. So the last Plasmodium species is Plasmodium falciparum, and this is the most severe form of malaria infection. The fever pattern for this Plasmodium is irregular, so there isn't a 24 or 48 or 72-hour pattern. It is irregular. And one thing that's very high yield to know for step 1 about this type of Plasmodium is that it invades red blood cells of any age. The other forms only invade reticulocytes, and that's why they cause less severe symptoms. But you can imagine that if this malaria is capable of invading any red blood cell in the bloodstream, it can cause much more dramatic and severe symptoms. Another feature of falciparum that leads to more severe disease is the presence of sticky knobs on red blood cell surfaces. So there are knobs in red blood cells infected with falciparum that are composed of parasite proteins. Plasmodium falciparum makes something called erythrocyte membrane protein 1, which is called PFEMP1, and this goes to the surface of red blood cells, and it looks like little knob-shaped proteins. And these knobs can bind to receptors on endothelial cells. This means that red blood cells infected with falciparum are more likely to glum up and occlude capillaries. This can lead to cerebral malaria. When you get occluded vessels in the brain, you can get altered consciousness and delirium and coma, and it can lead to renal failure, and this is how Plasmodium falciparum causes black water fever that I described before. The way you diagnose malaria is from a blood smear, and it's high yield to remember that you use the Giemsa or Wright stains. Remember that Giemsa in particular was created to identify malaria, and it's very good for intracellular organisms like malaria. The two things you may see in a blood sphere are a trophozoite ring or a schizont. So this is a trophozoite ring. It's a little circle here inside of the red blood cell. And over here we've got something with lots and lots of nuclei, and that is a schizont. And those nuclei are merozoites that it's getting ready to rupture and release into the plasma so that the merozoites can go on to infect other red blood cells. There are a couple of red blood cell features that make the red blood cells more or less vulnerable to Plasmodium infection, so let's talk about that now. First is the Duffy antigen. This antigen on the surface of red cells is necessary for Vivax to get inside the red cell, so if you have absence of the Duffy antigen, it is protective against this form of malaria. Sickle cells may have evolved as protection from malaria because children who have hemoglobin S have a lower risk of falciparum infection. And then finally, people with thalassemia also have less severe disease when they're infected with falciparum. That's because the parasite does not multiply as effectively as in patients who do not have thalassemia. Next, let's talk about some of the drugs used to treat malaria. And the first drug we'll discuss is chloroquine. This was one of the first treatments for malaria ever developed. Chloroquine is a weak base, so therefore it accumulates in the food vacuoles, which are acidic, of red blood cell trophozoite forms of Plasmodium. It blocks an enzyme that Plasmodium needs called heme polymerase. And the reason Plasmodium needs this is because the heme portion of hemoglobin is toxic to the parasite. So Plasmodium converts this to a non-toxic form using this enzyme. There's lots of chloroquine resistance. It's mainly used in very limited areas that are called chloroquine sensitive areas. It's not used for severe infections, and it only kills the erythrocytic forms, so it won't get the liver forms. And we talked about this before, and we'll talk about it again, but you have to use primaquine to treat those liver forms. And the only unique side effect to know about this drug is if you take it for long-term therapy, you can develop retinopathy and have vision problems. The malaria drugs other than chloroquine have complex mechanisms that you don't need to know for step one. You really just need to know the names of these drugs. So for severe infections, there are two IV drugs you can use. First is artesunate and the other is quinidine. Then there are some other oral drugs that are commonly used to treat malaria. One of them is called methylquine. This is used in areas where there's lots of chloroquine resistance. This is commonly given as prophylaxis to travelers. I took this when I went to Costa Rica, and it has one unique side effect that I remember very well. It gives you very vivid dreams. These are bizarre and unusual, and if you ever have to take this for prophylaxis, you'll never forget it. Another oral drug for malaria is primaquine, and as I said before, the most important thing to know about this drug is that it treats the liver phase of Vivax and Ovali. It's not active against the red blood cell phase, and primaquine is often given together with another drug in order to treat the liver phase, and the other drug will treat the red blood cell phase. And then finally, there's a drug called atovaquone that's often used for malaria as well. If you practice medicine in the United States, it's very unlikely you'll see any of the malaria drugs used to treat malaria. That's because malaria is very uncommon. Where you will sometimes see them used is in autoimmune disease to suppress the immune system. And that's because both chloroquine and hydroxychloroquine have immunosuppressive actions. Their mechanism of action to suppress the immune system is not clearly understood, but they have been shown to block toll-like receptors in B cells, which leads to decreased activation. In addition, they are weak bases, and they raise the pH in immune system cells, and it's believed that this makes them less active. There are also many other actions that have been described for these drugs. So you will see many patients on these drugs, particularly on hydroxychloroquine. It also goes by the name Plaquenil, and you will see patients taking that for rheumatoid arthritis and sometimes for lupus. The last thing I want to mention in this module is a G6 phosphodiesterase or G6PD deficiency. This is an X-linked genetic disorder. It's relatively rare, but it results in hemolytic anemia that's triggered by various stressors. And classic stressors are certain infections, fava beans, and many drugs. And you should know that many malaria drugs trigger anemia in G6PD. In particular, quinidine and primaquine can both trigger anemia in G6PD. So patients are often tested for a G6PD deficiency prior to treatment. So for example, if you're going to give primaquine to treat the liver phase of Vivax or Ovali, you will often test for this disorder. If you're going to give IV quinidine for life-threatening falciparum infections, you will also test for G6PD deficiency first. And that concludes our module on malaria.